Thank you again for joining us for today's webinar, where we'll be sharing the results of a new survey which shines a light on what physicians really think about new weight loss drugs. And with that, I'm going to hand it right over to our speakers to introduce themselves to you personally. So Frank, let's start with you.
All right. Well, so I'm Frank Dumont. I'm an internal medicine physician by training. I finished medical school back in 1997, so I've been doing this for a while. I spent the first 20 years of my practice practicing medicine the way that I was taught to do in medical school. And I really had a fair amount of pessimism in terms of people's ability to do lifestyle. And so when we start thinking about the GLP-1s, I probably would have been those reasonably enthusiastic prescribers of GLP-1s had I not stumbled upon the literature behind what we do at Virta. Now I'm in a very different place. I really do believe if we give people the right information, the right science, the right tools, the right support, they're able to do so much nutritionally that a lot of times these medicines become less necessary or unnecessary. But I'm really looking forward to the discussion, and I will now pass it over to Dr. Shetty.
Hi there. My name is Grishma Shetty. I'm an endocrinologist by training. I'm the director of quality and safety at Virta. And prior to joining Virta, I ran the Harvard Longwood Joslin Fellowship Program. And part of the reason I'm excited about the work we do at Virta is that we provide holistic continuous care, which frankly, I think is part of the problem with the medications that we're dealing with, is that we really need a solution that encompasses and offers a holistic solution. And I think that's what we are able to offer at Virta. I'll transition over to Kevin.
And good afternoon and good morning. Kevin Kumler, president at Virta. As you can tell, I'm the least credentialed person on the call. I'm not a physician. I do happen to be the son of a physician who struggled with obesity and type 2 diabetes his entire adult life, and unfortunately eventually passed from complications of type 2 diabetes, which is how I ended up at Virta. But for today's purposes, I'm here to share some exciting data from a national survey that we've conducted, and also to pull in some of the perspectives from Dr. Dumont and Dr. Shetty to help us understand what's going on in the minds of physicians around this rapidly evolving topic of GLP-1s. For those who aren't familiar with Virta, we're not going to spend a lot of time talking about us today. We're going to spend most of the time on the data and interpreting the data, but we are the leader in reversing diabetes and delivering sustainable weight loss through a combination of nutrition and technology. Many of you may already be familiar with that. And most of you are familiar with the market context for why we're talking today. Obesity is the largest and most rapidly growing health issue in the country. We have, by last data I've seen, only 12% of Americans are considered metabolically healthy, and we have 40% of our population living with obesity. If you add in overweight, diabetes, and prediabetes, it's nearly 80% of our adult population. And that is the backdrop for why there's a lot of excitement around the innovation and breakthrough for GLP-1s for many of these patients, but it doesn't come without some questions. And again, the market is evolving rapidly, which is why we want to bring some new data to the conversation. So before we dive into the data itself, just to share some background on the survey, this is a survey representative across the country of about 300 physicians. It's a mix of primary care physicians, endocrinologists, and obesity, board-certified obesity medicine specialists, spread across the country, as you can see on the graph on the right, and represented everything from academic medical centers to private practice. So really fairly representative sample when you think about who's out there writing the scripts for these weight loss drugs and diabetes drugs. And if you step back and think about how many patients that represents, it's over 500,000 patients represented by the people that we're talking to in this survey. So we're really excited at this as another window into what might be going on here. So why don't we walk through a couple of the results in just a second. But the first one, before we dig into the results of what the physician said, we wanted to see from the group on the call here today, we're going to ask you the same question. First question we asked the physicians: what do you expect to see in terms of GLP-1 prescription growth in 2024, either in your organization or your health plan? Please fill out the poll question now, and we'll share the results in a second. Then we'll compare that to what we heard from the physicians. So this is what we heard from physicians. None of them thought that there would be flat or decrease in GLP-1 prescriptions. And I guess that's probably to be expected. what I found surprising in looking through this data was the level of increase they did expect. Almost 90% thought it was going to double at least. And almost 60% thought it was going to be 3.5 times plus growth in GLP-1 prescriptions. If you compare that to what the pharmacy benefit managers are expecting, which is roughly 40% growth, it's a pretty significant increase to that. And again, these are the people who are holding the pens to write the scripts for these drugs. So very interesting to see what they're expecting coming forward.
So there you go. You should be able to see that. 36% of attendees today expect a 3.5 or more increase. 49, so about half, expect a 2x increase, and 12% expect an increase of 1x or less.
So actually pretty well aligned with the physician point of view that only about 10% expected doubling or less, almost 90% expected doubling or more, although not quite as many on the higher end of the spectrum as we saw among the physician community. So interesting to see that those are aligned and much higher than some of the prior forecast data coming into the year. So now that we're halfway through the year, maybe people have the advantage of knowing what's actually going on in their data to drive these numbers, but interesting to see. So moving to the next slide, this is just sharing some of the concerns that physicians raised through the survey. So none of them said that they weren't concerned about utilization. And in many cases, the vast majority said they were worried about the demand around these. And a lot of this likely being driven by the level of advertising around these drugs, but 85% were at least moderately concerned about the level of utilization of these drugs and in many cases likely how they're being used. And then if we jump to the next slide, demand for these drugs is only one of the concerns. These were the top 3 among the physicians we talked to. They're worried about the marketing practices. They're worried about supply chain, which is sort of the other side. Can we get the drugs to the right people enough? And then interestingly, for a bunch of physicians or a group of physicians, they're worried about them being misprescribed or overprescribed. And I'd assume that's not by themselves. They're thinking about their peers. But if you get a group of physicians that all view this as a potential concern, that was an interesting and maybe unexpected response. So I'd love to call in maybe Frank first and then Grishma. When you look at this, what do you see? How does this hit you from a physician's point of view?
Well, I think, Kevin, the thing that really struck me as I looked at the top 3 is what is not in the top 3. When we think about when new medications or new medication classes come into the market, one of the things that physicians are always trying to do is understand the data so that you can weigh the risks of a medicine or a medicine class against the potential benefits. Are we going to do more good or are we going to do more harm? That's what helps us understand when and how we should be applying these types of medications. And those weren't addressed at all, the risks of the medications. And these medicines have been around since the early 2000s. Bottom line is we've known about a lot of side effects going back then. We know there are other side effects that people are worried about with these newer weekly higher doses of medicines, and those didn't even make the top 3. And so when I think about that, it really makes me start to understand that the physicians appear to be very concerned about the social phenomenon that's going on here. That it's not just about medicines the way that we usually think about them. It's the way that these medicines are being viewed by and demanded by and being used by the public. So it's just a different perspective that I'm used to seeing with new medicines.
Thanks.
And
Dr.
Kevin,
you.
yeah, I would say along the lines of what Frank said, I agree with that. But I also think, these medications have been in the market for about 19 years, originally starting about 19 years ago. They do have a long track record and clinical trial data supporting their use for diabetes in particular with real cardio-renal benefit. So I think what this is reflecting is that the clinicians that we surveyed are the front line. They're the folks who want to make sure that the patients who need it the most have access. And that's been an issue with disruption to supply chain, cost, all of that. And so they really want to make sure the patients that they see who could benefit the most are able to access the treatment. And I think that really concerns people as they take care of a population of patients, making sure the right tool is getting to the patient who needs it the most and can benefit from it the most.
Thank you, Dr. Shetty. You teed up the next set of data from the study around expectations from these patients and how they're thinking about what might be possible through these drugs. And it seems like your physician colleagues are really concerned about those expectations. And this was encompassing not just outcomes, but everything around the drugs. What what might be the long-term effects of taking them, what lifestyle change they might have to take alongside, potential side effects. And the vast majority of physicians are showing some real concerns about the expectations that patients are coming to them with. Presumably they're seeing ads, stories on TikTok, et cetera, but maybe you could each talk to me, and I'll start with you, Dr. Shetty, on how this plays out in your office when patients come in with a certain set of expectations around a given therapy, and how that then impacts how you engage with them.
Yeah, for sure. So whenever you're taking care of folks with metabolic disorders, whether it's obesity, prediabetes, or diabetes, there's really no magic bullet. Medication is one sort of tool that we have in our bag, but really we need to look at the patient holistically and, look at their diet, their exercise, their sleep. There's so many components to care. And so really trying to find that personalized, holistic approach is critical. And I think where a lot of patients are ultimately find that there's disappointment is when they think one solution, one medication is going to create a long-lasting, sustained benefit. And I think that's the key. We want to really make sure that patients are set up for success. If they're going to be using novel, expensive therapy, we really want them to be able to optimize getting the most benefit out of it. And I think that's where trying to set expectations and other parts of their care plan that need to be integrated with the use of the medication, I think is really important.
Yeah, and I guess what I would jump in with is, again, just contrasting with what my experience was with most medicines that I was prescribing over 20 years as a PCP. The bottom line is that for the most part, people do not want to take medications. And so I spent a fair amount of my time trying to help patients understand the benefits of medicines compared to a lesser risk to try to encourage them to do things that would make a difference clinically. But the bottom line is sometimes it was difficult to get someone to take a blood pressure medicine or to take a cholesterol medicine. And these medicines are different. What we're seeing again is a very big demand coming from members and patients themselves, and I think sometimes some unrealistic expectations. This is a difficult area. This is a place metabolically where people have struggled. Everybody has tried and failed diets before or lifestyle changes before trying to control weight. And so they're really looking for solutions. And the data for these medications are very good when you look at the clinical trials, at least in the short term. And so the bottom line is that these people are looking for a solution desperately. They see really good numbers. They hear it being reinforced in the media and in places like TikTok or Facebook or other venues. And they, of course, get very enthusiastic about that because they want to be able to see something that's likely to give them some hope.
I like that silver lining in there, that high expectations is connected to hope and belief of better health, which we should all actually applaud and hope plays out. Double clicking into maybe one specific area around expectations was around efficacy, and almost 3/4 of the physicians felt like their patients were overestimating the efficacy of these GLP-1s, what it could do for them clinically. So maybe Dr. Shetty, again, starting with you, when you see this, what does that mean to you that patients are overestimating the efficacy?
Yeah, so again, here, I think, folks don't realize that in isolation, one therapy is not going to be a sustainable, long-term solution for metabolic health issues. And I think, unfortunately, we live in a time where a simple solution is always sought, but it actually takes hard work. It takes effort to sort of change your eating patterns, to add exercise and all of that. And so I think a solution for patients, where it's married to a lifestyle intervention and a medication is probably more likely to deliver sustainable results, because we know the majority of patients will come off these medications at 1 year and 85% will come off at 2 years. And then there's a rebound, which you've done nobody any favors if you've just provided a small interval of weight loss and then a rebound. In fact, sometimes that regain of weight could be harmful in itself.
Another great tee up for the next question we asked, and I think we'll try the polling experiment again before we share the actual data, but you did tee up the concept of sustainability. So we're going to throw up another question here for the group. How long, because we did ask the physicians the same question, how long do we believe that patients will be able to sustain these therapies over time? So I think we're going to try to put up that polling question if we can get the technology to work, and if not, we'll again keep going with the data.
I think we're going to need to keep going. Technology is not in our favor today.
All right, we'll dive in. I will give a quick side plug. I'm seeing questions start to pop up in the Q&A tab at the bottom. We have saved time at the end for questions, either on the survey, happy to share more if there's deeper questions on the data, and also questions for Dr. Shetty and Dr. Dumont to talk more about their perspectives, what they're seeing both in this data and more broadly. So again, when we asked the physicians how long they thought their patients would be able to sustain on this therapy, here's what they told us. Interestingly, none believed that GLP-1s would be sustainable for their patients for life, which is interesting because the data to date has shown that weight comes back if people get off the drugs. And this is saying the physicians don't view this today, at least, as a future statin where they're being prescribed this drug and maybe prescribed this regimen permanently. But roughly 10% thought that their patients would be able to sustain it for a year. The vast majority thought somewhere between 2 and 3 years, and almost 30% thought they might make it out to 4 or 5 years. So, maybe starting with Dr. Dumont, when you see this and think about sustainability for patients, does this surprise you? How do you interpret these findings?
Yeah, well, so I have a number of thoughts, and maybe I can start by going back to your question about effectiveness. This is a big piece of that, because when I think physicians are thinking about effectiveness, they really are thinking about what is going to be effective for my patient for the long term, what is really going to move the needle and help their health for the long term. And so I think that this really brings up the question of, is this really going to be effective? And it's part of this disconnect between what a member or a patient might be thinking in terms of effectiveness and what the physician is expecting. Now, the thing from my standpoint is that even though I think this is really interesting, that the majority of the physicians are saying these are not sustainable for the long term, they're not going to be the lifelong solution, it actually still isn't as grim as reality is. Dr. Shetty mentioned the Prime Therapeutics data showing that 1 in 7 individuals was still on the GLP-1 medication at the end of 2 years. So 61% here are saying 2 to 3 years. But the question that this really brings up to me then is, what is the long-term plan? If the medication is not the long-term plan, and Dr. Shetty's already touched on this, there needs to be another piece of the solution that allows you to work toward that day after coming off of the GLP-1. And of course, that's what we've focused on at Virta since our inception. We've been helping to manage medications like the GLP-1s going back to the beginning of our clinical trial in 2015. We prescribe the medicines when it's appropriate, but most of the time we're de-prescribing when people have improved enough that it's warranted and it's a safe thing to do. And when you give them the right information, the right tools about a real lifestyle change that is not only effective and demonstrated well in clinical trials, but is sustainable, that's the kind of thing that actually allows someone to come off of the medication and not lose all of that ground that they've gained potentially with the help of a medication.
Dr. Shetty, how about you? How do you interpret these? Does this surprise you?
No, I mean, I think that 4 to 5 year data, 28% still being on it, is a little higher than what we've seen. But I mean, again, so the most common side effects from these medications are gastrointestinal, nausea, vomiting, constipation, gallbladder disease. So that, the side effect profile is one reason that people don't sustain past a year. And then I would say for the 2 to 3 year group that falls off, I would say a lot of that is around cost and access and supply chain issues. And so I think those are the big drivers for that drop off by end of 2 years.
All right. Jumping into the next question, this was probably the data I was most surprised by in going through the whole survey, I have to say. So I can't wait to see what you both think about this. But the physicians that we surveyed here, again, fairly representative sample, believe that they're being prescribed more often than they should for weight loss. And I'll be interested to see how you both interpret that. And then the most shocking stat of the whole survey, almost all of them thought that prior auth was helpful for ensuring the patients with the right need are able to access this drug. I always thought of prior auth as a physician's worst nightmare and just friction that got in the way of their judgment. But here, almost all of them said it was helpful. So please help us understand this, because I just found this shocking. So Frank, if you want to jump in, and then Dr. Shetty, if you could follow up.
Yeah, well, so with regard to the first stat, the 75%, I think that in my mind, what this is likely to represent is the fact that a lot of people are being prescribed these medications before they're even trying other things which are well proven that are non-medicine based. And so I think maybe that's one of the big concerns that's showing itself here is that people really should be starting a lifestyle program, really trying to maximize that, and ideally one that's well founded in science. And then if needed, the medicine might be appropriate as an adjunct. That's the way that these were approved by the FDA. In terms of the prior auths, that was a surprising statistic because I don't think that I have ever asked for a prior auth to be put in place to make my life any easier as a physician. But I think what it really goes back to is the top three concerns that we saw previously, that physicians do have concerns about the use of these medications, whether we're talking about the way that they're being marketed or the access issues that I know we've touched on, or whether it's with regard to the possibility of overprescribing or misprescribing. I think that people are acknowledging, the physicians are acknowledging that there is an issue here and that we ought to be trying to do something, again, to make sure that we're using the medicines in the right places and trying to use them appropriately so that they're as available for the people who really need them as possible.
Yeah, Kevin, I agree. And like Frank said, I don't think I've ever looked at a prior auth and said, yes, I want to fill this out. So I think what that is, though, it's probably a surrogate for physicians want to be good stewards of resources in our healthcare system and make sure that we have tools in place to make sure that we are able to maximize the benefit of these drugs to the populations who see the most benefit from them. And then when we do use them, that we set patients up for long-term benefit. So I think this is sort of I don't think anyone wants prior authorization. I think some people want tools to help them use it more effectively across a population.
Thank you both for shining a little bit of a light on that. Slightly less confusing to me now than it was before, but still, I have to say, the most surprising of the things we saw. So you both mentioned lifestyle and how to combine these drugs with lifestyle to get the best outcomes. We also asked this group what lifestyle they recommended. Traditional diet and exercise was number one, virtually all of them. Surprising, at least to us at Virta, we do have a point of view on this, was the low carbohydrate diet was number two. Again, virtually unanimous in terms of it being an effective approach. Followed after that by the whole food or plant-based diet, nutritional therapy programs in general, and then the Mediterranean diet coming in at only 1 and 4. So this to me flies a little bit in the face of the mainstream point of view on nutrition. I know we see a lot of data supporting low carbohydrate. I have not seen data suggesting the Mediterranean would be that low. So if either of you have thoughts on this, would love to hear it, because again, I found this a little bit surprising from a physician point of view.
I can go ahead and then I'll pass off to Frank. So I'm a little surprised by this as well. And I think our physicians that we polled were skewed to obesity medicine and endocrinology. We did have a lot of primary care doctors, but I think maybe these are the folks who really have experience with obesity management and really do see the benefit of a low carb diet. And so I was pretty impressed with this, the way it's skewed out, but I don't know if we polled folks who actually were more familiar with successful nutritional interventions in obesity.
I think the thing that I would add is that most physicians have a lot of experience recommending the Mediterranean diet to patients for decades, for years and for decades, and they just haven't seen the metabolic success that we would all hope for. It's part of the pessimism that I had for 20 years as a PCP, is making recommendations, thinking that would help, not seeing people improve, and then having to resort to things like medications. So I think that there is a kind of a skepticism for something that you've been trying for years and decades that just has not been effective. Now, in contrast, one of the joys that I have working here at Virta is when I do hear back from PCPs or endocrinologists where we share patients and they see someone coming back after a lower carbohydrate approach where they really see the impact happening quickly and sustainably, and they get very enthusiastic about it and say, keep doing what you're doing because it's clearly working for your body. I think that's part of it. We are seeing a shift there with people having an understanding that this is one of those interventions that actually does have the potential to move metabolic health.
Super. Thank you both. And please keep the questions coming in. We are queuing them up for the Q&A, which we'll get to in just a minute. A couple additional thoughts we wanted to share as we again reflected on this feedback that physicians are clearly looking for help and support in this time of extreme change innovation, new drugs available, lots of consumer demand. So what kind of support can we give them to help support patients? In general, we view this as supporting them and their patients across the entire weight loss journey. So for those who haven't yet gotten to a GLP-1, we talked a lot about lifestyle. Clearly, the physicians polled here believe in that. Before somebody even gets to a GLP-1, they can be steered towards alternatives for this. And there are some ways that we are doing that with our partners today. For those, once they're on a GLP-1, making sure they're paired with the right lifestyle intervention so they can get the optimal results. And then, again, as showed in this data and shown in the real world data, people are very unlikely to take these drugs for life. So there has to be an off-ramp plan. So how can we safely and sustainably deprescribe people who have been on these drugs and achieve their health goals and help them maintain that health throughout the rest of their life without having to continue to take on the drug? So maybe to click into each of these for just a brief second. On the first one, we've published data on this comparing real world Virta results. So those who are only doing drug-free weight loss and those who've taken the drugs. Interestingly, on the left-hand side, this is for people for just weight loss, not for type 2 diabetes. You see that nutritional therapy has very similar results in terms of the actual weight lost. The percentages show what percent lost at least 5% or at least 10% of their weight. You can see dark blue being our nutritional therapy, coaching support technology versus just the drug, almost identical. If you look at the same real world results for the people with type 2 diabetes, who are a little bit more complex, we actually see stronger long-term results on weight loss with nutritional therapy than with the drugs. So again, that's comparing maybe before we get somebody to the drug, can we get them onto a new lifestyle change in advance? But for those, once they're taking the drug, how do we make sure we get optimal results? So on the next slide, we have a point of view on that too. And the real world just hasn't matched up to the clinical trial in terms of weight loss results on these drugs. So the far left is typical clinical trial experience on GLP-1s, 15% plus weight loss at a year. In the middle is what we've seen in the real world data. And this shouldn't be a surprise because clinical trials tend to be higher support, well-controlled, not just people getting the prescription and then being, heading back home, heading to the pharmacy, picking up the drug and having to figure everything else out. On the far right, we see in a model like Virta's where they're getting an individualized plan, they're getting the right support, the physicians with them kind of throughout the journey. We see similar weight loss to what they saw in the clinical trial. So I don't think that should be a big surprise, but it does highlight that if you have a plan that is just based on the drug being covered or not covered, having prior auth or no prior auth, and you're not putting thought into what's the support the patient needs and that physician care team needs, you probably shouldn't expect to see the kind of eye-popping weight loss results that came from the clinical trial. And then lastly, for those who are getting off the drug, how do we make sure they maintain their weight loss? So we published data earlier this year contrasting the experience of our members who were on a GLP-1 and were deprescribed versus those who had been followed in the clinical trials. The dotted red line is the rebound that many of you are probably familiar with and was discussed earlier, that those coming off of these drugs regained almost all of the weight within a year. If we contrast that with those who had the right nutritional therapy program, lifestyle, and support, we actually saw it 6 months and 12 months later, almost the same weight loss as they had seen the day that they stopped taking the drug. So we do think this is a really important part of especially the healthcare value equation here. If you're going to invest in these drugs for your community, you need to pair it with something to ensure you're going to get the results you're looking for over time from those drugs. So one quick plug for people who might be interested in learning more. We're not going to talk a lot about it today, but we have had a lot of demand in the market for customers who want a group of physicians who have a lot of experience with these drugs and are likely more on the conservative side and ensuring that it's always paired with lifestyle counseling and ideally an off-ramp when the patient gets to the on-ramp. So we've been working with our pharmacy benefit manager partners and our health plan partners to help ensure Virta can be a trusted prescriber network. So think of this as a weight loss center of excellence, and our team happy to answer questions offline on this. But this is an area where we've seen a ton of growth and interest because people do want to make sure that access to these drugs can be had for the population so they can get the results that we've seen, but want to make sure they're doing it in a really thoughtful way. Lastly, the low carb comment came up earlier, and many people view this as a restrictive approach, and it is. We are telling people to eat fewer carbs. But two things that we've learned over time. Number one, it doesn't have to be all or nothing from day one. People can take baby steps, and for some members who aren't ready to take a bigger leap and be fully adherent from day one, we found that baby steps are a great way to get them to start to change their lifestyle, start to see results. But on the flip side, it's also true that there's an extreme dose response curve here. So the more you can adhere to a low carb lifestyle, you tend to see much better results. So these are two of the things that kind of underline our philosophy on approaching helping people adopt a low carb lifestyle. And a few more of our guiding principles are in the next slide on how we think about food, making sure that patients are eating real food. Fat can actually be your friend, which is something that is scary for a lot of the members that we're first talking to who don't have a lot of experience and education on nutrition. But healthy fats can really help people feel satiated, so they're not snacking on stuff that's less healthy for them and eating those empty calories, making sure they get the right balance of plants and protein. Number four, really making sure that it's paired to them, because everyone's physical and biological reaction to food will be slightly different. So a huge part of this is an individual journey. And then making sure that that plan is adjusted over time to ensure results, not for a week or a month or wedding season, but ensuring they get the health results they want for the rest of their life. So that has to be part of the plan. Right, I know we've got a lot of questions to get to, and I think now is the time we're going to jump into it. There will be probably a poll that may come out afterwards to get your feedback on today, but first we want to jump into some of the questions from the group. So first question, do we have an idea in the interest in different specialists for the GLP-1? So getting out of just primary care into things like orthopedics, cardiovascular, and others. So maybe I'll turn that to you, Frank, as the internist. How do you think about some of the different specialists and what you're hearing from them and their interest in these drugs?
Well, I think a couple of thoughts come to mind. The first is that metabolic health affects the body top to bottom. And so I think regardless of your specialty, it is likely to be heavily involved by a person's metabolic health. In the setting of orthopedic surgery, you're dealing with joints that are dealing with the wear and tear that comes along with the weight. If you're dealing with OBGYN, you're dealing with the reproductive issues, the hormone imbalances that can come along with excess weight, etc. So the bottom line is I think everyone is paying attention and everyone is looking for solutions and ways of trying to put the solutions all together in a way that's really going to impact health going forward. The other thing that I would say, and Dr. Shetty, you probably can shed more light on this, is that there are studies coming out, it seems like every other week, with regard to newer data of other areas that are impacted by the GLP-1 medications. And so I think there's a lot of hope that as we use the medicines more, we start to understand the places where they're particularly helpful, and that's across multiple specialties.
Dr. Shetty, anything you'd add there?
Yeah, just to follow up on that. Yes, so we know the GLP-1s have significant cardiorenal benefit. That's been well established in many randomized controlled trials. We have new data about the combo GLP-GIP medication also potentially having, and those studies are ongoing. There's multiple new molecules in the pipeline that are in phase 3 trials that are dual and triple agonists. And so these medications, one, they'll be new, so they'll probably help with the current indications, but they may also have new potential indications ranging from addiction behavior, use in type 1 diabetes, liver disease, neurodegenerative disorders. So as we expand these indications and the trial data comes out, we'll have to be able to make sure that we're able to appropriately provide access to the patients who are going to see the most benefit from these newer medications as well.
Thank you both. Another question to help us jump into the mind of the physician in this survey. So I'll give this to both of you, and it comes from one of our friends who's a senior HR benefits leader out there, really looking for clarity here. And I'll read her question verbatim. What I don't understand is that these polled physicians, primary care, endocrinologists, obesity certified physicians, they're prescribing GLP-1s. However, they're concerned about over or misprescribing. How do you explain this incongruency? Do they believe that this is from other physicians who are jumping on the prescribing bandwagon? or due to patient pressure from direct-to-consumer marketing. So what's going on here? All these people who are actually writing the scripts are saying they're worried about overprescription. Is this a pot in the kettle black situation? What's going on here?
Well, I guess I can jump in. I think, physicians in general feel like they're trying to do the right thing for their patient that is sitting in front of them. But even in that situation, it's often a complex equation. And so I think that the pressure that sometimes physicians do feel by a patient who has struggled and is really hoping for a solution, I think physicians sometimes feel some degree of obligation to work with them to try to meet them where they are and provide something, even if they think that it might not be the way that they would do it if they were just making the decision based on the data. The other thing that I think is really clear is that there are entities that have popped up during the last couple of years when GLP-1s have gained so much popularity that are really focused on just prescribing these medications very quickly and maybe without much screening or clinical analysis before prescribing. And so I think there is some concern about the quote pill mills as well.
Yeah, and I would just add that I think physicians are put in a little bit of an untenable position of where they see the risk benefit ratio that we look at anytime we start a treatment. So, for example, if you have a patient who potentially has a real cardiovascular indication, because we know that these medications used in folks with diabetes or obesity with a pre-existing history of cardiac disease, they actually have a mortality benefit being on these medications. So feeling like you're struggling to get these medications for those high-risk patients who could see real mortality benefit and feeling like you have to sort of limit or restrict because of access issues. Meanwhile, you don't want to be in the position of having to decide whose medical need is more important. And so trying to balance that. And then finally, physicians using these medications, like we've had these medications for 19 years. So we know, we have seen that they work for a couple of years while you're on it. But then if you come off of it, you lose all the gains. So it's really trying to figure out that sweet spot of getting the medication to the right person, getting the best outcomes you can, and then giving them the plan for the long-term health benefit. And I think those are a lot of things to ask. And I think that's why we're hitting that sort of like paradox of why are they saying this, but yet at the same time, they want someone to help with it.
Yeah, goes back to that hope. They've seen some of the data. They've also seen that it can help some patients, but it highlights the need to have a more holistic program in place. A bunch of questions have come in on this topic, and it may be because people have been reading the news lately, but a bunch of questions on compounding. So are there concerns relative to the compounding pharmacies? Some people gave examples of Henry, LifeMD, that are emerging. Are these effective? And what impact do you see them having with patients, health plan costs, et cetera? So I don't know if either of you wants to be the first one to wade into the topic of compounding pharmacies, but I'd love to hear your perspectives.
I mean, this is something that comes up every time that we're dealing with a medication with a significant cost or access issues. And so this is not a new problem. I can remember this happening with certain antibiotics back when I was in practice and particularly in the hospital setting. So I certainly understand where it's coming from. And I understand people thinking that this might be a solution to some of the access issues and the cost issues. I think the concern that we always have as physicians, though, is do we have enough data to suggest that we're doing more benefit than harm? And there have been concerns with regard to some of the compounding pharmacies about the quality of the product, the purity of the product, the concentrations of the product. And the bottom line is if someone is getting something other than what they expect, we have the potential to be doing harm rather than good. And so, that is why the FDA process is as stringent as it is with regard to drug manufacturers. And this is bypassing that to some degree. And so I think there's reason to understand it, but there's also reason to be concerned and to think that this probably is not the right solution to fix the problems that we're dealing with in terms of cost and access.
All right, I'll jump into the next question then. Several questions on rebates. How will lifestyle programs or Virta taking over GLP-1 medication prescription from the PCP, medical plan carrier, pharmacy carrier impact rebate provisions? This is a topic that we've actually dove into quite deeply with our partners and customers. I can say a couple things with some certainty. Number one, rebates really come down to the contract between the manufacturer typically and the pharmacy benefit manager, and sometimes with the employer health plan sponsor. So it really is contract dependent, and it can vary from contract to contract, relationship to relationship. So I can't say anything that is definitive across the board. What I can say is in the scenarios where we are putting in this trusted prescriber network, there are ways to do it in a way to ensure that people are getting access to the medication and you're not impacting your rebates. So that problem has been solved and can be solved, but the specific solution can vary from situation to situation based on the contracts in place. So feel free to reach out to our team and we can help with that. Back to our doctors, a bunch of questions that were following up on the sustainability question. Do you believe the sustainability would be better with an evidence-based tapering regimen, perhaps a longer interval between injections? And then regarding the sustainability, is this because of the out-of-pocket costs or because they're not long-term safe medications? What's the drop-off? So it's sort of two questions in there. First one, will evidence-based tapering help? And the second one being, why are people dropping off? Is this out-of-pocket or long-term safety concerns?
So I think a lot of the rapid fall off in the first year is probably related to gastrointestinal side effects, and folks just don't tolerate it, and so they stop it. A lot of folks, once they achieve their goal, they like to come off medications. People don't want to be on medications long term. It's expensive. It's an injection. And beyond that, really to impact sustainability, I mean, we've seen at Virta when we implement a very personalized plan where you're focusing on behavior and nutritional changes, you can see sustained benefits. I know Kevin showed that slide from earlier this year. So again, I think this is part of when you're dealing with a metabolic health issue, there's not one single solution. You need to have it sort of a holistic wraparound with changing behavior to be brought in with the medication. And I think this is a little bit about precision medicine, like meeting each patient individually where they are, having a coach who's going to be focused on their nutrition and tracking along with them and helping them make those changes that are sustainable for them. Frank, I don't know if you wanted to add anything else to that.
Well, I think going to the other question, which is, more along the lines of, actually I just blanked on the question. Kevin, can you repeat that for me?
Sure can. The two parts were around sustainability. The first one was evidence-based tapering regimen.
Oh, that was it. Okay, thank you. So the bottom line is that we don't have data for that yet. And so, the way that these medicines have been stopped has really been, I think, variable at this point in time. And so we don't have data to say that tapering them in a different way is necessarily going to give a better outcome. What I can talk about from a data standpoint is our clinical data, which we presented in the slide that Kevin showed. We were able to deprescribe people very rapidly from these medicines when they had achieved enough metabolic success to be able to do that appropriately and safely. And so that often came in just a couple of very quick tapers. Sometimes it was just an abrupt stopping of the medication. And the interesting thing, again, is that if you had implemented an effective lifestyle before doing that, then you were able to sustain those benefits, whether it was sugar control or whether it was weight reduction and being able to maintain that loss of weight. That was achievable even with a very rapid taper. And so in my mind, when I think about the recidivism that we see, it's not so much about how slowly we back off on the medication. It's about really having that other piece of the puzzle, which really helps people sustain the benefits that they got from the medication.
Great. Thank you, Frank. That may have partially answered the next question, but for either of you, what natural remedies can serve as a proxy for GLP-1 medications?
I don't know that there's a natural remedy that mimics the potency and efficacy of GLP-1s. Yeah, I don't.
I guess, I'm looking at the question a little bit differently rather than trying to see some kind of a naturopathic approach. Nutrition, I think, is the thing that, of course, we focus on. And, I think that has, according to the data in the real world, the ability to achieve the same magnitude of weight loss and actually better sustainability. I mean, as we've talked about the fall off on these medications and the recidivism, the weight regain when people stop the medicines, which the majority of them do. In contrast, with a nutritional approach that has the ability to decrease hunger based upon matching nutrition up with metabolism. So you get a lot of the same benefits of the GLP-1s, decreased appetite, decreased cravings, decreased food noise in your head. that if you get that kind of an approach and the support around it, we've actually seen sustainability that is well in excess of what we've seen with the medications. And so from our clinical trial, what I would just mention is that 1 year, our retention rate was 83%, 2 years, 74%, 3.5 years, 65%, and out to 5 years, nearly 50%. And when you can get nearly 50% of people doing something for 5 years and maintaining those benefits like better sugar control and weight loss, to me, that strikes me as an extremely good natural approach, an alternative to a medication type approach.
So one way to then answer that might be healthy fats. Healthy fats can help suppress the appetite, really reduce some of those hunger pains and cravings, and in that way, maybe achieve some of the same results. All right, back to Dr. Shetty. That somebody else is stuck on the same data point that I had been around 97% of doctors being in favor of prior auth. They found this shocking too. Do you think that the high response to prior auth being helpful might be related to prescribers' difficulty saying no to inappropriate requests from patients? So that if the prior auth is denied because the request was clinically inappropriate, the insurance company's the bad guy instead of the prescriber.
I think that might be part of it, but I really think more comprehensively looking for sort of a tool to make sure that, again, the folks that are going to see the maximum benefit and the most risk reduction are able to access these medications. I think a more systematic approach right now, especially when there is access issues and scarcity, I think that's more what they're looking for. But I agreed, like when a patient asks for a treatment that you don't think is clinically indicated, it's hard to say no when you're sitting in the office with them. And so sort of having someone else look at it and say, like, I'm not going to approve it. I guess that is a level of having a tool to support your decision.
And I would say that we have a long history of that in the field of medicine. The best example that comes to my mind is antibiotic use. And we've known for a long time that there are many conditions that patients come in hoping to get an antibiotic to a doctor's office. And more often than we care to admit, the doctor will prescribe that prescription. It will prescribe that medication because it's quick and they give the person what they need. The person is satisfied and they can move on to the next patient they're working with. And so even though we know that that is not the right thing, it's not good antibiotic stewardship, and it increases all kinds of problems downstream. When you look at the data, what we know is that we as physicians still do that. And so having that tool to be able to say, there's a reason why I can't do this, probably is a piece of that reality.
Yeah, that's a good spot to give a plug to my personal primary care physician, where every time I go in with cold or flu and I ask for a Z-Pak, he says no. And it's frustrating in the moment, but I know he's doing the right thing because it's not actually going to help me get any better, and it's certainly bad for population health. Question on how can employers offer GLP-1 coverage in a responsible way? So I think that's a good summary question for a lot of the things we've hit on in here. I think we would say that GLP-1s should be covered. They can be a breakthrough medication for many patients in the right circumstances. So if you're going to cover them in a responsible way, that means likely having the right prior authorizations in place to make sure that people who get this are clinically appropriate, having the right thoughtful physicians in place so that they are prescribing this for the right people, and having the wraparound and support on lifestyle so that those who are willing to try lifestyle only first have that option, are educated on it, and can do that before trying the drugs. And then for those who are getting on the drugs, they're getting on it with an off-ramp in the future in mind so that whatever gains they make, they're sustainable over time. So another question, this one for Dr. Dumont. How do you think the new indications for cardiovascular events will impact take-up and integration of GLP-1s with lifestyle changes?
Oh, well, I think that it's going to continue to increase demand at this point. And I think to an extent, it continues to amplify the difficulty that we're running into with regard to access. I mean, so the bottom line is that every time that there is a new indication, we have, the whole group of physicians that are seeing those data and wanting to help their patients, especially patients that are dealing with serious conditions already, like cardiovascular disease. And so it's going to make them want to be more effective at systematically prescribing those to the right people. And yet right now we're seeing this tremendous problem with regard to access in people with diabetes, in people with cardiovascular disease that don't have the ability to get these medications because of the demand more broadly across the population. So in my mind, yes, I think new indications are going to increase demand. They're also going to amplify the access issues that we're struggling with.
Thank you. Another question, we've heard rumors that manufacturers won't provide rebates if a plan tries to put in additional guardrails in place. For example, only for BMI of over 30. Have you heard if there's any truth to this? I can say from our personal experience, it really varies from manufacturer to manufacturer and from specific collections of relationships. So some manufacturers with some PBMs and some employers and or health plans are far more willing to figure out how to create a plan that is both going to have high clinical impact and be cost effective. And there are others who are adhering more to the letter of the law of their contracts and the FDA label. So it can vary, but if you want to talk about this more, please feel free to reach out to our team and we can share some specific examples. But it's not a one size fits all, yes or no. But we have seen in general there are ways to work around it because the manufacturers, they want these drugs to be approved and covered and taken up. And the more that there's cost sharing in place for patients and the drugs aren't covered, the less uptake that they're going to see over time. So happy to work with you all on that. Another question for Dr. Shetty. Are there specialties that will be concerned about GLP-1s?
I think actually a lot of specialties are actually probably going to be moving in the other direction, seeing potential new indications and benefit. And so, as I've mentioned, there's clearly been evidence for the GLP-1s with cardiorenal benefit. There's going to probably be benefits, again, investigational right now, but for liver disease, addiction, behavior, neurodegenerative, these are all exciting potential. They're all in trial, so no known indications yet, but I'm sure folks are going to be watching this eagerly. So I think there will be more specialists sort of following the GLP-1 / family very closely.
Thank you.
I would say that there are probably a couple of specialties that are just, especially in the inpatient setting, struggling a little bit just with the increased complications that they are seeing. And so I don't know that that would mean that they wouldn't see the overall benefit of the class of medicine. But if you're someone who's a hospitalist or a general surgeon and you have more people that are coming into your facility because of bowel motility issues, the gut slowing down enough that someone actually ends up in the emergency department and then admitted to the hospital, and they've recently been started on a medication that happens to have that as a side effect, or pancreatitis when there's a known association, with these medications. Those are the types of things that we are seeing more in the ERs and the hospitals, and that I think those specialists are probably feeling to some extent, but they might very well be able to accept that that's just in the context of a bigger picture.
Great, thank you. I guess a question for either or both of you. What do you attribute the uptake and interest in GLP-1s? In your opinion, is this social media, the rising obesity trend, or marketing?
Should we say all of the above? So I think from again, metabolic health perspective, there's a lot of data that there's a lot of benefit. So obviously from that standpoint, I think from a society-wise perspective, obesity and sort of all the downstream health consequences from obesity are dramatic. So people are searching for a solution to sort of improve their long-term health. And then, of course, social media and the pharmaceuticals industry messaging also probably drives a lot of that as well.
Yeah,
I would agree that it's all of the above, but I think that there is a kind of a desperation that comes with people that feel, when you see the prevalence of obesity in our society and you realize that's approaching 50% of the United States adult population. So you're well aware of it from a societal standpoint. Most of us then have at least some reality on that, either with regard to overweight or obesity, and certainly when we start taking into consideration family members and friends, and you see the way people are struggling. And you think about just how many people have tried doing things, tried very hard, whether it's exercising more or trying diet after diet, or just all kinds of different approaches and failing. There's a kind of a desperation there that really sets people up to look for those glimmers of hope that they can move toward, and hoping for the same types of benefits that they're seeing in social media.
Yeah, as a layperson, not a physician, but an economist and sometimes health historian, I'd say the interest in miracle cures for weight loss well preceded the obesity epidemic in the US. So I don't know that this is necessarily a brand new thing, but it's certainly a story we've seen before in some ways. So that would at least give a little extra weighting in the all of the above, maybe to the marketing side. A question for either of you. As a registered nurse who is on this journey personally as well, kudos to you for emphasizing the well-balanced lifestyle chain as the long-term solution. While GLP-1s can be part of the answer, I really appreciate your emphasis as clinicians on the long-term change in diet, exercise, and sleep. I'd love your thoughts on a modified Mediterranean diet, low carb with an emphasis on local sourcing and whole food.
So, I mean, I think if you're tracking for progress and you're doing well, again, I don't want to be too prescriptive about the diet. I think we at Virta have really great, robust experience with very low carb. But we do have patients even within Virta who are on sort of different ranges of carb intake. And as long as you're tracking towards better and improved health outcomes in each individual patient, I think that's where it is. I don't think there's a magic number that you need to hang your hat on. I think if you're seeing progress and you're achieving the results you want in your metabolic outcomes, I think that's the right fit for you. I think we live in a very diverse, genetically diverse community, and what works in a South Asian may not work in a Latino, may not work in a Caucasian, it may not work in a man or a woman. So I think really personalizing, and I think this is where the art of medicine is. It's precision and meeting each patient with what they need and their body needs. So that was a long
One of the
answer.
things just to add on to that, it's one of the things that I really enjoy about being here at Virta is that we are listening to the body objectively with those biomarkers that are letting us hear how the body is responding. And then you can adjust from there. You're adjusting based on data as opposed to adjusting purely based on hypothesis. And you don't have to wait months or years to see if it's successful. You're seeing that happen in real time. And the other thing is that individualization that Dr. Shetty was talking about, that we have experience with diverse groups across the population in the United States, very different demographics, people of different backgrounds, people of different socioeconomic status. And the really exciting thing is that when we look at the data for A1C reduction or weight loss or the ability to deprescribe medicines, it is the same across those different demographics. And the reason for that is not because of just one piece of what we do. It's really about that individualization, being able to individualize based on what the body is telling us about what it can handle and what it can't, but also what the person is telling us about what matches up with their world, with their life, so that it's something that they can truly do well, and do sustainably.
So I know we didn't get to every question on the list, but we really enjoyed the engagement here. As you can all tell, we love this conversation. So if we didn't get to your question, please feel free to reach out. Some of you shared your email addresses, so we will follow up directly. But just huge thanks to Dr. Newmont and Dr. Shetty for shining a light on the physician perspective around this rapidly changing time in these drugs based on a ton of experience. And now that we're at the top of the hour, we'll let everyone run on to the next part of their day. And thank you so much for joining us.